Everyone, I'm myself Dr. Dipti Kariya, and today we'll discuss about motor tracts. They're also known as descending tracts or pyramidal tracts. Now, motor pathway. They convey motor impulses from brain to spinal cord, and therefore they are known as descending tracts. These descending tracts are mainly of two types. One that is corticospinal tracts, which are also known as pyramidal tracts, and second one they are extrapyramidal tracts. We'll discuss. Now, starting with corticospinal tract. As I told you, they are also known as pyramidal tracts. Now, this is the longest tract. They start from motor cortex, and they reach up to the last segment of the spinal cord. So they are the longest tract in human being. They are present in higher animals and human being. Okay, and the myelination, although they are present since birth, but that myelination is completed by the age of 2 years. And this myelinated fibers, 70% of fibers are myelinated, and the diameter is about 4 to 22 micron. Okay, these myelinated fibers, they have tendency to disappear in old age, and that is the reason for automatic shivering movements. Now, these fibers of the pyramidal tracts, they are axons of upper motor neuron. Okay, upper motor neurons. Okay, they are also known as pyramidal neurons. Now, other variety of tracts, they are corticobulbar tracts. They are also present. This corticobulbar, which are also known as corticonuclear tract. Okay, this pyramidal tract fibers, this corticobulbar. Here I am writing it corticobulbar or cortical nuclear also. Other name for that is this pyramidal tract fibers to the motor cranial nuclei. They are cranial nuclei number 5, number 7, and number 12. They are from corticobulbar or corticonuclear tract, and these fibers, they begin in the cerebral cortex and they end in this nerve nuclei in the brainstem. Now we discuss about corticospinal tracts, which are the major pyramidal tracts. Okay, now this fibers, pyramidal tract fibers, they originate from area number 4, 6, and somatosensory area. 30% of their fibers, they originate from area number 4. Here you can see this is area number 4, motor cortex, primary motor cortex. Area number 6, here it is, and somatosensory area, that is area number 3, 1, and 2. From this, the fibers, they originate. Now we'll discuss about the course. After taking origin, these fibers, they originate here. You can see after they originated, this pyramidal tract fibers, they run downward. Okay, and they are first there in the diffuse manner, and then they form corona radiata, means they are fan like this one. You can see here diffusely. Okay, and that is known as corona radiata. In brainstem, this corona radiata, they form internal capsule. You can see here this is internal capsule, and this internal capsule is between, here is thalamus, medially thalamus, as well as caudate nucleus, this one, and laterally there is lenticular nucleus. This is lenticular nucleus, globus pallidus and putamen. Okay, now, these pyramidal tract fibers, they lie in genu and anterior two-thirds of the posterior limb of the internal capsule. This is internal capsule like this one. Okay, this one. So, in genu and anterior two-thirds of the posterior limb of internal capsule, these pyramidal tract fibers are located. There is point-to-point discrimination in this internal capsule fibers. Fibers which are concerned with the control of head, shoulder, elbow, wrist, and finger, trunk, hip, knee, and toe. They are arranged from anterior to posterior. So anterior most fibers, they are for the toe movement, then gradually knee, hip, trunk, okay, like that. Then in the midbrain, here, sorry, in the midbrain, here it can be, these fibers, they are located anteriorly. Okay, they are ventral to the substantia nigra, and they occupy middle 3/5 of this region. And in the medulla, then in the pons, these fibers, they are again located in the most ventral aspect, and here these fibers, they are broken down in series of scattered bundles, and this is known as nuclei pontis. Then in the medulla, the scattered fibers, they uh, reunite and they form bundle, that is pyramids. Pyramids are formed in the medulla, and therefore also these tracts are also known as pyramidal tracts. Okay. Now, In the lower part of medulla, what happens, you can see here in the lower part of medulla, this tract fibers, they most of the fibers, 80% of the fibers, they are crossed, and they form lateral corticospinal tracts, which are also known as crossed pyramidal tract. Okay, and remaining 15 to 20% fibers, they are uncrossed, and they form anterior corticospinal tracts, which are also known as uncrossed pyramidal tract. Okay, phylogenetically, this anterior corticospinal tract fibers, they are old one. Okay, and lateral one, they are newer one. Now, termination. These fibers, you can see here, this lateral as well as anterior corticospinal tract fibers, they end on the motor neurons of the anterior gray horn, this here. Okay, so you can see here, these fibers are upper motor neurons. Upper motor neurons are the neurons, they originate from this pyramid, originate from this motor cortex. Okay, these are upper motor neurons. So this upper motor neurons are the pyramidal tracts, and lower motor neurons are this one. They originate from here, anterior horn, ventral horn of the spinal cord. Okay, now, of all these pyramidal tract fibers, there is also one important thing here you have to remember is 55% fibers, they end in the cervical region. 20% fibers, they end in thoracic, and 25% fibers, they end in the lumbosacral region. Okay. Now, what are the functions of this pyramidal tracts? Number one, first function is they control voluntary and skillful motor activity. Lateral corticospinal tract fibers, mainly they convey motor impulses to the spinal cord. Okay, and this is for controlling voluntary activity, mainly for the distal limb muscle, and they are very important for fine and precise movements of fingers and hands, and that is required during skillful activity. Fine. So this is one of the very important function of the pyramidal tract. Anterior corticospinal tract fibers, they are concerned with the control of the muscles of the trunk. Anterior one, they are older one, so they are concerned with the motor activity of the trunk, also for the proximal part of the limb, and mainly these are required for the postural adjustment, required for the cross movement and postural adjustment. Okay. Next function of this tract, that is the part of the pathway of superficial reflexes. So for superficial reflexes, this motor neurons are required. Third function of this tract is excite or inhibit lower motor neurons. Some of the corticospinal fibers, they have excitatory synapses with alpha and gamma motor neurons. So they can excite or inhibit this motor neuron to which they have synapses. So they act, either they excite or inhibit lower motor neuron. And fourth function, that is sensory motor coordination, because 40%, as we have discussed, 40% fibers of these pyramidal tracts, they originate from somatosensory cortex. Therefore, they are concerned with the sensory motor coordination also. Okay, and what happens when there is lesion of this tract? Because of the lesion of this tract, motor performance that is affected. The person is having inability to execute learned sequence of movement. Because of lesion, there is loss of voluntary movement, muscle tone is also affected. There is in upper motor neuron lesion, there is spastic paralysis and reflexes. Superficial reflexes are lost and deep reflexes are exaggerated in upper motor neuron lesion. Okay. Now, applied physiology, here one more applied aspect is most common site for the lesion of pyramidal tract, that is in the internal capsule. Internal capsule. And what is the region for this lesion? That is thrombosis, uh, or you can say hemorrhage of, try to remember the name of the artery, that is lenticulostriate artery. Lenticulostriate artery. And this is the branch of middle cerebral artery. Branch of middle cerebral artery. Okay, fine. So this fibers, when they get affected, okay, because of thrombosis of the lenticulostriate artery, okay, there is a apoplexy, or that is also known as stroke, that is sudden attack of paralysis. And if there is damage to area number 4, that results in, if the damage is in the area number 4, motor area, okay, from which this tracts they originate, that results in monoplegia, means paralysis of one limb. Then if there is damage in the internal capsule, that results in hemiplegia, that is half paralysis. Okay, damage to brainstem level, when there is lesion in the tract at the level of brainstem, that results in paraplegia, paralysis of lower limbs. And if there is a or sometimes it may produce quadriplegia also. All the four limbs are paralyzed. Quadriplegia. Okay. Okay. Upper motor neuron, lower motor neuron, we will discuss in detail. Now, next is extrapyramidal tracts. This extrapyramidal tracts are the descending tracts other than pyramidal tracts. They are known as extrapyramidal tracts. All the from all other areas of the brain, different fibers, they descend. They are extrapyramidal tract. These are also motor pathway and they are multisynaptic. Let us enumerate first name of all this extrapyramidal tract and then we'll discuss. One, that is medial longitudinal fasciculus. Second one, vestibulospinal tract, then reticulospinal tract, tectospinal tract, rubrospinal and oligospinal tract we will discuss. You can see here I have shown all these tracts here. First, medial longitudinal fasciculus here, that is that is not visible here. I'll show other tracks. Vestibulospinal tract, lateral here you can see this is vestibulospinal tract, then reticulospinal tract, tectospinal tract. Okay, here this one in the spinal cord, olivospinal tract. Okay, we will discuss one by one. Now, so starting with first one, that is medial longitudinal fasciculus. This tract fibers, they originate from vestibular nuclei one, then reticular formation, then superior colliculus, and interstitial cells of Kajal. These are the areas from which medial longitudinal fascicular fibers they originate. And what is the course after entering the spinal cord? These fibers they descend through posterior part of the anterior white column in the spinal cord. Here you can see here in the anterior white column, posterior part of the anterior white column through which they pass. Okay, they descend. Okay, and they are up to upper cervical segments of the spinal cord, and they are terminated on the alpha motor neurons either directly or through interneurons. That is the termination on the alpha motor neuron. What are the functions of medial longitudinal fasciculus? Number one, that is concerned with the coordination of reflex ocular movement. Reflex, because superior colliculi related with ocular movement, ocular reflexes. Okay, ocular movement. Also, another function, that is integration of not only ocular but ocular and neck movement. Then third function, that is simultaneous movement of lips and tongue as in speech. Okay. And what are the effects of lesion? All this reflex ocular movement, reflex neck movement, they all are lost. Okay. Next extrapyramidal tract, that is anterior vestibulospinal tract. They are located here. You can see this is also here. They are located in the anterior white column here. Originate from medial vestibular nucleus in the medulla oblongata. Okay. And they run down from the medulla into the anterior white column here, and they terminate again on the alpha motor neurons either directly or through interneurons, alpha motor neurons. And what are the functions? These tracts, they receive fibers from the vestibular apparatus, as they are vestibulospinal, so vestibular apparatus. So they mainly from the semicircular canals, and they are important for the reflex adjustment of the position of the head and body during angular and linear acceleration. Okay, then comes lateral vestibulospinal tract. These are located in the lateral white column here. You can see. Okay, they originate from lateral vestibular nucleus, which is also known as Dieter's nucleus. Lateral vestibular nucleus. These fibers are arranged somatotrophically. Fibers from the cervical segments, they originate from cranioventral part. Then so that if you remember, that is fine. Otherwise, okay. Now they extend. They pass throughout the spinal cord. Okay, and they these tract fibers, they are also their function. They also end on the alpha motor neurons directly or through interneurons, and their functions are also same. They are also concerned with the they also these fibers are also concerned with the movement of help in the adjustment of position of head and body during angular and linear acceleration. Okay, now next is reticulospinal tract. This reticulospinal tract here, they are medullary and pontine. Reticulospinal tract, medullary originate from medullary reticular nuclei and pontine from the pons, and location, they are located in the lateral and anterior white column. Medullary reticulospinal tract in the lateral white column, and pontine, that is in the anterior white column, originate from reticular nuclei in the pons and medulla. They extend up to thoracic segment only. Okay, and they terminate again here. The important thing, reticulospinal tract, they terminate on gamma motor neuron also. Okay, gamma motor neuron. And what are the functions? Their function is postural adjustment of adjustment of head, trunk, and limb. Okay, and lesion that results in a disturbance in this adjustment. Another important function here is pontine and reticular and medullary reticular formation. They also have action on other movements like voluntary and reflex movements, which are facilitated by pontine reticular formation fibers, whereas inhibited by medullary one. Muscle tone, that is facilitated by pontine reticular formation and inhibited by medullary one. For respiration also, pontine, that is concerned with the expiration, and medullary one, that is concerned with the inspiration. And in blood vessel, pontine reticular fibers, they cause vasoconstriction, and medullary, they cause vasodilatation. Next, that is tactospinal tract. This tactospinal tract, that is located in the anterior white column, you can see here. They originate from superior colliculus, tectum, as superior and inferior colliculi. So this tract, they originate from superior colliculus, and they extend up to lower cervical segments. They again terminate on the alpha motor neurons, either directly or through interneurons. Okay, and their functions, they are related with the movement of the head in response to visual and auditory stimuli. Movement of head in response to visual and auditory stimuli. Then rubrospinal tracts. These rubrospinal tracts are located in the lateral white column here. They originate from red nucleus. Okay, the name itself suggests magnocellular nucleus of the neurons of the red nucleus. Okay, that is located in the midbrain, and they extend up to thoracic segment. Thoracic segment. Then they cross to midline. You can see here this red nucleus, and then they cross to midline. Here you can see, and they terminate here. Of course, they cross the midline and they descend the spinal cord through reticular formation in the pons and medulla, and they terminate on the interneurons along with corticospinal tract. What are the functions of rubrospinal tract? This rubrospinal tract fibers, they act as an alternative route of the for the pyramidal system to exert influence on the lower motor neuron. And these tracts, they facilitate flexures and inhibit extensions. Next one, that is olivospinal tract here, that is located in the lateral white funiculus, originate from inferior olivary nucleus here. Okay, in the medulla oblongata, and this tract fibers terminate again on the alpha motor neurons of the spinal cord, and their functions, they receive afferent impulses from the cerebral cortex, corpus striatum, red nucleus, and the spinal cord. Now, what are the functions, basic functions of extrapyramidal tract? Extrapyramidal tract, they are important for the maintenance of tone, posture, and equilibrium. They are also important for the control of coordinated movements. And whenever there is damage to the pyramidal tract, some of the functions are carried out by extrapyramidal tract. But when there is lesion of both, that results in release phenomena, because our lower motor neurons are released from the controlling effect of both extrapyramidal and pyramidal tracts. Okay, now we'll discuss one thing about upper and lower motor neuron. Okay, so now what is upper motor neuron first, and what is lower motor neuron? Upper motor neuron lesion and lower motor. First of all, we should know what is upper motor neuron. Upper motor neurons are our pyramidal and extrapyramidal tracts. Pyramidal and extrapyramidal neurons, they are upper motor neuron. Lower motor neurons are motor neurons of spinal and cranial nerve nuclei. Okay, now this what happens in case of upper motor neuron lesion? muscle tone of the muscle increases when there is upper motor neuron lesion, whereas in lower motor neuron it decreases hypotonia. So in upper motor neuron lesion the paralysis is spastic paralysis, and in lower motor neuron lesion the paralysis is flaccid paralysis. In upper motor neuron lesion there is no wasting of the muscle is seen, because group of the muscles are affected. Here you can see it is written group of the muscles are affected, whereas in lower motor neuron lesion single muscle is affected and there is wasting of the muscle is seen. Superficial reflexes are lost in upper motor neuron lesion and deep reflexes are exaggerated, whereas in lower motor neuron lesion both the reflexes are lost. Babinski sign is positive in upper motor neuron lesion and negative in lower motor neuron lesion. Okay, and electrical activity that is normal in upper motor neuron lesion and that is absent in lower motor neuron lesion. Clonus is present in upper motor neuron lesion and absent in lower motor neuron lesion. So this is all about our descending tracks. You will get all my notes in the link which is given in the description box. Thank you so much. Thanks for watching me.